Good morning. It is finally Friday. It's August 27th. Welcome into the Morning Medical Update. It is Follow-Up Friday. Also, we're going to get answers to some of your most asked about questions throughout the week. Joining me today, of course, is Chief Medical Officer Dr. Steve Stites, along with Dr. Brandon Comfort. He is back. He works alongside COVID long haulers and with our long hauler clinic. So we're going to talk a little bit about that coming up in just a bit. And as always, Dr. Hawkinson joins us to answer your questions. But first, let's get to our numbers this morning. Hi, good morning.
Hi. Numbers are holding steady. Again, they're about the same, but that doesn't mean that we haven't had additions and subtractions from this. Currently 62 active infections with 24 in the ICU, 14 on the ventilator, but 37 additional in that recovery period, so a total of 99. But again, even though the active numbers of infections really stayed about similar, we should say that we have had some admissions, but unfortunately we had 2 deaths over the last 24 hours as well. So overall, since the pandemic began, we've had 485 COVID deaths, COVID-related deaths. Again, 500 is not a milestone we want to get to. We did have 2 deaths within the last 24 hours. Hays also has 11 active infections and none in that recovery period, so a total of 11. But, hopefully the numbers of active infections can go down because people are recovering and getting out of the hospital and not, having this mortality and deaths that we're seeing.
All right. We don't like the numbers, but thanks for the update, Dr. Hawkinson. Dr. Comfort, Dr. Stites, we're going to get to reporter questions. Just wanted to welcome you both in.
Hey, thank you. A little concerned. The numbers are still staying pretty high. We had our chief medical officer call yesterday, and numbers are up overall for the CMO team and across the city. Second only to our peaks in January. We were in the mid-600s. We're in the high 500s right now on what we call the big 6 hospitals, the core 6 hospitals, which are the ones that have been reporting their data all along with us. And we had our CMOs yesterday, and we may have even had a little higher peak of right over the weekend and down just a touch now. Some of that has to do with transfer center availability. When you don't, the hospitals tend to open up a few more beds on the weekends and you can take in more transfer center. And what I would just caution everybody to remember is that our numbers are really high now, but that's without an active transfer center because we're turning down 2/3, 3/4 of the transfer requests we have. We usually accept 2/3 or 3/4, but we just don't have the bed capacity to do that, right? So that's a concern. Second thing, and I'm glad Dr. Comfort's here today. Important study. We both walked in. Hawkeye walked in. I walked in. We both said, "Did you see the Lancet article?" Talking about up to 50% of patients can have long haul symptoms for a year. That's a really long time, and that's a really high number.
Oh yeah, it completely is. And I think when we first started down this post-COVID efforts here at KU, we were optimistic that this was going to be a weeks to months sort of recovery period for people. And I think studies like this in the Lancet, there's one in the Clinical Infectious Disease Journal as well. We're looking like this is going to be months to years before we have full recovery for some of our patients.
We keep talking about death, but the reality is suffering, right?
Yeah.
This is tough. And, I know we've been a little bit edgier trying to get people to, and there was not a plan. There's no real strategy for us to do that. I think, Hawkeye, that you and I, we've been doing this for a very long time. Jess, we've been doing it a long time. Our whole team's been doing it a very long time. You've been doing this a very long time. I think what's happened is we're all getting we're getting our own cows going, right? COVID weariness syndrome. We're all thinking we're getting a little tired of COVID. And the worst part is that it is just so dadgum preventable. And that's the part that just bugs the heck out of you. And I think that you see some of our websites out there where people are commenting, they're getting like, "Oh, you guys are getting too much of this." And there's some more negative comments out there. But folks, here's what we're doing. We're just trying to tell you the truth. We have absolutely no motivation here to lie to you. There is no motivation about that. So we're trying to tell you the whole truth and nothing but the truth, so help us God. Because at the end of the day, our job is health. We are physicians and folks involved in healthcare like yourself, Jess, and others. Our job is trying to keep you healthy. We've got no other motivation. We really don't. I don't have like investments in pharmaceuticals. I don't go around and give talks for big pharma and stuff. I got none of that here. I'm just trying to keep folks healthy. That's the job. And we're just going to keep on telling you the truth. And what we tell you may feel counter to some of the things you read in other places or your personal beliefs. And, I'm sorry that's true, but it's not going to divert us from telling you the dadgum truth, because that's our job. And if we start lying to you on a regular basis, this is no longer a morning medical update. It's part of the made-up news network That is not who we are.
You know what I've noticed is that just you haven't wavered on anything you've said, and the same type of questions have come throughout the last year and a half.
Yep.
And the answers are still the same. Happy to answer the same questions because we know people have them, but they haven't changed. And if they change, it's only because new data has come in,
right?
And we share the same data every time.
Yep. You know, and we're the first to say that. You look back at those first two pictures, we're all huddled around the telephone together. It's like, okay, that's wrong, man. We didn't do that right.
I wish we knew.
Well, we just didn't know,
Yeah.
but we know, right? We know, and what has clearly come out is this is a incredibly transmittable respiratory virus, and that the rules of infection control work. And I don't know why people ignore this, but they try to ignore this. We prove it every day, right here in the hospital, with our own employees, our own staff who don't get COVID from our large number of COVID positive patients. If we don't transmit it here, because we're all wearing a mask, if we don't transmit it here, then you won't transmit it at home. But for some reason, people want to go up and make up other news about it and try and cite studies that don't exist and some other or misinterpret the ones that are out there. Here's the real data. Think about this. Just think for a minute. If there's no transmission inside hospitals where patients inhabit entire floors with COVID, if we don't transmit it, what are we doing? We're all wearing masks. There is no, it's incontrovertible proof that masking works. But instead, we can get a lot of people get sick, and that's a terrible idea. So is that edgy? Was I edgy there?
A little edgy for a Friday, but I like it.
Okay, well, that's
like
where it is. Telling you the truth.
I appreciate it. Let's keep telling the truth. Let's ask if there's some reporter questions on the line. What do we got? I hear nothing. Okay, so let's, okay, so start sending in your community questions today. So we're going to get to those here in just a minute. But I have a couple things I want to get to. We want another reminder for you out there about the free vaccination clinic tomorrow, Saturday, August 28th. It's from 10 until 2 down at the City Market. Again, it is free. So just look for the KCMO mobile vaccine truck. It's right there in front of the big paddle wheel near the Farmers Market Pavilion. You can get all 3 vaccines down there. All 3 types of vaccines will be available. Your second shots will be scheduled then through the KCMO Health Department. And if you're going to get your second shot down there, don't forget to bring your vaccination card. And you do not need an appointment. You can just show up in the City Market. So get down there if you have not been vaccinated. We also want to show you something that we kind of find pretty super interesting. Okay, so this guy next to me always says the rules of infection prevention travel with you wherever. And in this case, whenever you go. So come to find out, this advice has been around, Dr. Stites. I know you've been sharing it, but it's been around for like 100 years.
Yeah, maybe longer. I think Hawkeye probably knows it better even than I do because he lives it as an infectious disease doc and does such a great job. Yeah. You know, this is pretty funny. If you just sit and read it from 1919, right? 1919, is that what it says? I can't read it from here.
1918.
1918. Even a year older than that. So, you know, look at what it says. Look at the advice around masking and social distancing related to the great flu pandemic, the black flu or whatever we call it.
Wear a mask is number one, by the way.
Wear a mask. And
there we go.
If you've gone back and read into the articles, I've read some of the articles from the New York Times, how controversial then masking was. It feels like today, you could take every one of these rules and apply them right now today, and you could take the articles from the New York Times, although people wrote a little differently back then, or any other, the Kansas City Star or any place else, and just you could show how it just applies today. You could drop that article in the day and it'd be the same darn fight. It's amazing to me that we can still be having the same discussions then and now.
Dr. Hawkinson says this all the time. So you weren't kidding?
No.
Okay.
I wasn't kidding.
100 years.
100 years, but I have. Oh no, I'm going to end the show with that. I've got.
Okay, you got a good one.
I got a good one for today. So hang on, folks, people.
That's a good tease. You got something. You got something brewing in there. Okay, let's bring in Dr. Comfort. I just want you to tell our viewers a little bit about the patients that you're caring for and what, if anything, has changed when it comes to some long haul symptoms.
Yeah, happy to do so. So, you know, the post-COVID clinic is remaining very busy. We've had over 800 appointments now that have been completed. We have another 344 to 350, somewhere in that range, scheduled throughout the end of the year. So I think what we're seeing is that need for these services continues to grow, unfortunately. Just as we've seen the cases go up, we're going to expect more and more patients. Our clinic is seeing a lot like what other people are seeing. So number one complaint we're seeing is fatigue, debilitating fatigue. I've said it before, this is not like our run-of-the-mill, I'm run down a little bit. I've had patients that literally can't walk from the parking garage into our clinic without stopping to rest. Debilitating exhaustion and fatigue. We're seeing a lot of pulmonary problems, shortness of breath, cough, many patients needing oxygen long term, cardiac problems, neuropsychiatric problems, you run the gamut. So we're seeing a lot of different things. The theme is very debilitating symptoms on the whole that are lingering for a very long time. Now, what's on the horizon or what's new? So we talked about a little bit. There's a Lancet article. There's another article on clinical infectious disease. We're starting to get data at the 1 year mark. And so before it's 3-6 months, now we're at the 1 year mark. What we're seeing is about 30% up to 50% of patients that are sick enough in their acute phase that they need hospitalization, they're having symptoms a year out. So that is a huge number. So Dr. Hawkinson just told us that we have about 100 patients in the hospital right now. We would expect about 28, 30, up to 50 of those patients a year from now still having symptoms. So that's something that we're going to follow very closely. How long do people have these symptoms? The other thing that we're watching very closely is the vaccine. So not just to prevent disease, but to treat long COVID. So there are studies being done right now looking at this. Nothing's been published yet. Some informal data out of the UK is showing that up to 57% of patients who have long COVID that are getting the vaccine are getting better, or at least having improvement. So that might be our only treatment so far, like a targeted treatment. And so we are absolutely recommending the vaccine to all of our long haulers. I know there's been some hesitancy in that group in particular. So those are some things that we're watching closely.
Can I ask you a quick question? So are you seeing a long haul syndrome in people who have gotten COVID after the vaccination?
So we have not yet. There's one, we had somebody that got COVID after having the first vaccine, the Pfizer vaccine, and then got COVID, then developed some long COVID symptoms thereafter. I think we're going to see some. So if you get COVID, you're at risk of getting long COVID, whether you've been vaccinated or not. Our expectation or what we would anticipate is that it'll be at a lower rate, but we don't know that yet.
But 90% of our patients, Hawk, who are hospitalized are not vaccinated.
Correct. Yeah. And again, around the city and around the country, we certainly have heard those numbers about 95 to 98% of the people that are in the hospital and or dying are unvaccinated. Our numbers are a little bit less as far as unvaccinated, but I think that's selection bias in the patients that we get. We definitely get more transfers, more of the ill patients. We have more of those immunosuppressed patients, solid organ transplant. But as we saw a week ago, we had, 2% of our patients in the hospital were vaccinated, so 98% of the patients
we're vaccinated. So it's very few. And I
were
think
unvaccinated.
And when you look at the folks who are vaccinated, especially ones who are in the ICU, they've all got, you just look at that, you just look at their problems. We all look at their charts. You look at that and you're like, okay, you just never responded to the vaccine. And I think that's the other thing we're going to have to try figuring out what are measures. Someday we'll figure out to be smart enough, although I know antibody titers are beginning to be thought of as a marker for that. I'll be curious to see what you think. We've got to have a better marker of vaccine response so we know who to give vaccine to, because we got big groups of data, but we need to have N of 1 data, meaning we got to figure it out in everybody.
Yeah, and hopefully for the additional dosing for those immunosuppressed patients, that may offer more protection. Hopefully we'll see less of those patients in the hospital with that additional dosing that has been recommended now.
I have a question from KMBC, media question, asking about supplies. Are there any concerns about hearing anything about a syringe shortage, any sort of supply shortage?
There was an issue around some syringes back, I want to say, in the January part of the surge. I'm not hearing that right now. I don't know if anybody else is. I don't know about that. We've had some near issues around some medications, but I think right now supply chain is not the issue for us at the moment. For us, it's really the rules of infection control and whether people follow those, because we know that if you follow the rules, you'll be safe. And just as an example, interesting article this morning out of Denmark, where they have had, where they're saying that with 80% vaccination rate, that COVID is no longer a social disease, and they're rescinding all restrictions. But it's all about 80% vaccination.
Yeah, and I saw that today too, and so I did a quick little comparison of the United States to Denmark. So we have to understand, we talked about this yesterday, it's difficult to compare one country to another. Certainly it's difficult to compare the United States to any other country, especially a country maybe in Europe like that, who I think their population is, what, 5 million? The United States population is much higher than that. Their landmass is much higher. We also understand that a lot of those European countries or Asian countries, there's a different cultural aspect to that, where they are more for their country, their culture, less division within that. So again, I think with the population size, the density, all of that, but it is a good it's a good sign of optimism that they can do that, just as you said, with that high vaccination rate.
I think that's really the key, and I think you're absolutely right. A smaller country, more homogeneous population, and the belief system is a little more public health oriented. And so as a result, they've been able to enact all the measures, and I think that's why they've been able to master that disease, and hopefully they'll be able to keep it down. I'm a little nervous when people have all restrictions go away, that's going to be successful. But we'll see. It's an interesting experiment. And the mere fact in a country that is very public health oriented, they feel safe enough to do that makes a major step about a statement. And by the way, their 80% vaccination rate, what Fauci say, 80 to 85% of people need to be vaccinated, it tracks, right?
Yeah.
It's right on.
And they also said that they really want to get those done by, what, September 10th?
Yeah.
But should things change, because they are going to be constantly monitoring, interventions will be brought back in as well.
You bet.
So.
All right, we're going to get to some follow-up Friday questions. Are you good? You ready?
Roll, baby.
All right, let's
go.
roll it. Okay, and we'll try to get to some more questions coming in today if we can roll through these. Okay, so the first question is, have we seen a case of the Lambda variant?
I don't know that we track that per se. The Lambda variant really has not been a big deal like the Delta variant.
No, I think early on, maybe in the spring when there was some Alpha, there was some maybe early Delta, all of those things. I thought we had, I know we had something of that Brazil variant, which was Beta maybe. So we had, I think we had all those, but unfortunately what we have seen, both in our community, around the country, and really in a lot of nations, is that the Delta variant has really surged, has outcompeted, has shown to be more fit for one reason or another, and so really has taken over in many of these areas. And right now there is no other significant variant of concern that we're seeing in any specific geographic region. Delta has really seemed to be outcompeting other viral variants at this point.
Next question, how are therapies coming along? If we cannot fight this with enough people getting vaccinated, how are we doing with coming up with ways to keep people out of the hospital?
We actually, just to say, we know how to keep people out of the hospital. Right, we know how to keep people out of the hospital. It's called masking plus vaccination equals live long and prosper. And yep, right there. And so, and I say that, but it's really the perfect turn of phrase, right? You do want to live long and prosper. You don't want to have long COVID. You don't want to have to be sick for a long period of time. So how do you do that? Well, you do the things that we know keep you safe. We knew they kept you safe in 1918. We know they keep you safe in 2021. Wear a mask, put some distance between you and folks, and then get vaccinated, which they didn't have back in 1918. So I think that we do know. Well, what other therapies are coming along? Monoclonal antibody therapies are good, right? The data is really clear. It can reduce hospitalization by 75-80%. So in high-risk patients, you get monoclonal antibodies. That can be really successful. Beyond that, it's all we really need. I think Mario Castro in the room, but there are a lot of things that are aiming at drug development still to try and help shorten the course of it. There are some thoughts about ways to do that, or maybe even to find ways to do a subcutaneous injection so you don't have to go in and get an infusion, but to give yourself a shot in the arm, kind of like you would give yourself an insulin injection that may help. But basically it's a monoclonal antibody kind of therapy, but you would just give it to yourself at home, which would be a much easier thing. So I don't know, Hawk, other things that you're hearing about?
No, I would agree. We know that there are other therapies that are being investigated, but right now we have really the same therapies we've had for a year, and that is the remdesivir therapy if you're an inpatient, along with steroids, dexamethasone if you meet that criteria, and of course anticoagulation. You mentioned as an outpatient the monoclonal antibodies, which are very effective currently still at protecting those high-risk people from going to the hospital and having progression of disease as well. But there are other companies that are looking at, number one, repurposed drugs, so drugs that are out there for other reasons, that they are looking at interventions for COVID-19, but also new types of drugs. And again, just as you said, we've heard Mario Castro talk about those as well in the trials here that are going on at the University of Kansas Medical Center as well.
I think one of our challenges had been that when COVID numbers dropped off in the March because of a combination of vaccine and social distancing, masking, et cetera, we were down to 2 acute patients for a while, which was, we all felt so darn good about that. And now you've got a situation in Hawaii, for example, where they have 2,000 hospital beds, 1,500 new positive patients daily, and they're asking tourists not to come anymore. And the difference between then and now is the difference with driven by the Delta variant and with the loss of social distancing and masking measures. And so that clearly has made the difference. And now we're starting to be able to accrue into those trials again. When we didn't have as much COVID in the spring, it was hard to accrue into trials because we just didn't have as many people being sick. But that's changing, and I think accrual is picking up.
Okay, I do have a question for Dr. Comfort. Some long hauler questions are coming in for you. So Deborah says, I'm a COVID long hauler 18 months post-COVID, not tested at the time due to it being so early on. Cannot seem to get help because I never received that positive COVID test. Do you feel the T-Detect test that is now available could help tell if I had COVID so I can get help?
Boy, that's a great question. I don't know that I know the answer to that. I'm not that familiar with that test. I'm not sure if that's something, Dr. Hawkinson, you've seen much on.
The T-Detect test, yeah.
I don't know about it, but you guys keep talking. I'll be looking it up while we're sitting here.
I think it's a T-cell test. I believe it looks for reactions of your T-cells to, I think, the N protein of the virus. So that means if you've had the virus, your body, your immune cells should have been exposed to that protein. They can take those cells, give some M protein, and look to see if it reacts. If it reacts, you know that you've had COVID in the past.
So, Dr. Comfort, then somebody like Deborah, can she not be treated for long haulers because she didn't have a positive test?
Yeah, so we have set the criteria that we required a positive test. We set that kind of early on. That's something that we'll probably be revisiting as time goes on, as tests like this come up. We did that as a way just to ensure that we were getting the appropriate patients as we were trying to learn about this, as we were trying to learn how to treat this. We just set that criteria. But we know that there are a lot of people out there early in the pandemic, they didn't get the test because it wasn't widely available. We don't want to exclude them, so that's something that we'll be revisiting in the future.
Any advice for someone like her in the meantime? What would someone like that do? Just get in with her doctor?
Yeah, so her primary care doctor should be the primary source of information on that. And so by and large, as we mentioned earlier, we don't have a universal treatment for long COVID. It's really a rehabilitation-focused disease. And so I think getting connected with some of our rehab specialists is really going to be key. Physical therapy, occupational therapy, speech therapy, that's really the core tenets of our long COVID treatment. And I think that can really be done in a lot of places.
Yeah. So here's what it looks like. It is exactly what you've described. They're looking at the adaptive T-cell response. It's under early use authorization by the FDA. If it's negative, it doesn't mean, though, that you didn't have COVID. You may have lacked a response. If it's positive, it means you probably did. And it's a send-out test.
Yeah. And so just to be clear, the N protein that we're talking about that's on the virus is totally different than the spike protein that you would have gotten vaccinated with. So if you just had the vaccine and did not have the virus, really that T-cell response or test should be negative. With the caveat that Dr. Stites mentioned, if it's negative, it doesn't mean that you didn't have it. But certainly if it is positive, that means you've had contact with the virus itself.
And since there's going to be biologic variation within, which is a way of saying we all have a little bit of a different T-cell adaptive response here, that the test, again, if it's positive, it means something. If it's negative, it probably doesn't mean as much.
Okay, so Dr. Hawkinson, this person says, I'm scheduled for my second shingle shot this weekend. How soon after can I get the booster shot for COVID?
Yeah, early on, because we had very little experience with the COVID-19 vaccines, there was that recommendation to wait 2 weeks between dosing for any vaccine around the COVID vaccine. But that has since changed, especially with the ability to give pediatrics 12 and over vaccines. We didn't want to miss any time to give vaccines to for those vaccine preventable diseases. So basically right now is you can get multiple doses, multiple vaccines at the same visit. So you really don't have to wait any minimal time before you get either one of those either one of those shots. Now, if you're not immunocompromised, there really is no guidance right now for additional dosing or third dosing of COVID-19 vaccine, just to be clear. We will be waiting for that. I think it's going to be less than a month that they're going to be publishing guidance on that. But.
Dr. Comfort, Norma says, loss of taste, is there something to treat that with? Had COVID in October of last year.
Yeah, this
Any
is
remedies?
Yeah, this is a very common one, and this seems to be lingering well after a year with a lot of our patients. And so in the ENT department here, they're doing smell therapy. So just like we do physical therapy and occupational therapy, they do smell therapy. And it's really, things you can do at home. We've seen some kind of home kind of exercises, so to speak, you could do, smelling coffee, essential oils, other things that are kind of powerful aromas that may help re-stimulate, retrain some of those nerves that we used to smell with. So,
I love the smell of coffee.
Yeah. Could you imagine not being able to smell your coffee in the morning?
Well, I can't drink it because it hates me back, but I love the smell of it.
So you don't drink coffee?
I don't drink coffee. I am naturally hyper, and so it doesn't take coffee for me to do it. And the reason I don't drink coffee, it gives terrible heartburn and reflux, so I had to give up coffee.
Okay.
Makes me cough. Meh.
I feel bad.
Yeah.
Okay, so here's one for you, Dr. Stites. A friend thinks that taking vitamin C and D will prevent COVID, and that she'd want ivermectin or hydroxychloroquine to cure it if she got it. How does one convince her that this is fake and to just get the vaccine?
First of all, I'm so appreciative of this question because this person does not want to be a rumor reporter, a rumory. Remember that one?
Yeah.
Rumories. Don't want to be a rumory because you're not listening to the made-up news network, the MUNs. Gosh, I don't know how to have this conversation, honestly. I wish it did. I try to do this in clinic every day when I'm there with my patients and folks who don't believe in vaccination and things. And I think, there are days I just want to get angry and frustrated or very edgy. At the end of the day, I think you just have to love people and you just have to love on them and just keep trying to talk with them and saying, and just keep putting more and more evidence in front of them, including the number of patients who say to us, as they go into the ICU and can't breathe, I don't know, I didn't believe. They believe this other stuff because somehow it fit a personal belief or a political narrative in their lives that it said to them that vaccination's fake, COVID's a hoax, this isn't really that bad, and I can take horse pills or dog pills, whatever, heartworm pills to make myself better, like ivermectin. And at the end of the day, those of us who've been doing this our entire lives, you turn to us when you have a broken bone. You turn to us when you have a heart attack and when you have a stroke or you have cancer or when you have to give chemotherapy drugs. Why do people want to turn to us when they're sick like that, but turn away when they have COVID or about COVID? It's a funny think, right? It's a funny think. I want my doctor and I want to turn to you, except when I don't. And that don't is defined by COVID. That's a funny don't. And I don't know how to convince people otherwise than to say to your friend, do you believe the physician, your doc, when they talk to you about your treatment for your high blood pressure, the treatment for your diabetes, the treatment for... And if that's part of your core beliefs, why don't you believe us when we talk about COVID-19? I don't know. And then you get some of those physicians out there who are trying to push ivermectin, but if 99% of physicians are telling you that that's a bad idea, that 1% of physicians are trying to say that it's a good idea, maybe they're wrong. Maybe they're wrong. And the other question to ask yourself is, how many of these post-COVID patients who have long haul wish that they had been vaccinated, or they, it's just this odd dichotomy to me. And the puzzle that no one can ever answer is, how come we can keep all our employees safe in a hospital?
Have you had patients turn to you with genuine questions about the vaccine, and then
absolutely.
They come back later or text you or call you and say, after talking with you, I decided to get it? And how does that feel?
Yeah, no, it feels great. Yesterday I was 0 for 2. The clinic prior to that, I was 3 for 3.
Okay.
And so on average, I'm batting about 600.
Good.
Although if I kind of went back a little further, I'd probably not be 600. It'd look more like baseball. And I think it feels really. Actually, the clinic staff celebrate with you when you say, I got one, COVID. We're going to give a shot. And they're
Like
like,
ring a bell or something, right?
"Yay!" Yeah, it's like that. And, people, we want to keep people healthy. We don't want folks lining up. 1,000 people lined up for the post-COVID long-haul clinic. And it's the tip of the iceberg, man.
Dr. Covert, I'm sure you've had people bend your ear and ask you tons of questions, and they were on the fence and they came down off the fence. That's got to feel good.
Oh, it feels really good. It happens every day we're having this conversation. We have seen an uptick in vaccine acceptance in our clinic, and I think as cases rise, that risk rises. It's pushed some people kind of off that fence. I think the FDA approval of the Pfizer series is really big for a lot of our patients. And so I still believe there's a lot of patients out there willing to get the vaccine. We just got to reach them.
Yeah, one by one.
One by one.
One by one. Okay, so here, Dr. Hawkinson.
Yeah, so I'd like to say that
Sorry.
I'm still here.
Oh, you're over here.
Go, brother.
Hi.
Go, brother.
I haven't left yet.
Hawkeye.
I don't have clinic just yet. I'd like to say it's really difficult when you don't know where that person's source of truth is. So we can just continue to promote the accurate sources of truth that have been vetted. Places like the CDC, the NIH treatment guidelines are readily available on the internet. A place that I like to go to is the Regulatory Affairs Professional Society, which is RAPS.org. There, in their search thing, you can type in either therapeutics tracker or vaccine tracker. And when you do therapeutics tracker, you can see all of the drugs that are being investigated, what stage they are. You can also see where many of the worldwide, but also United States organizations like the FDA and the World Health Organization, the NIH, stand on some of these treatments. And so it's just a matter of understanding and picking exactly what are the sources of truth, because if that other person, if their sources of truth are wholly inaccurate, but that's what they're believing, it's going to be difficult for them to change their mind or reduce their hesitancy.
Well, we have a lot of people who will write in and say, where do I send people? Where do I tell them to go? If they're not watching this show, where else can I send them to go to get real information? So that's really helpful.
Yeah, and I think we had Logan pull that up, or Anthony, so thank you.
Perfect.
And the CDC has an app, and you just download the app in your convenient app store and put it on your phone. And sorry, I'm on the mic. God, you know what? I am not trainable, guys. I apologize for that.
Was he banging the mic, or was he hitting
I was banging. Probably my shirt was up there rubbing on it. Not trainable, but I believe my doctor. But that CDC app is really good. It's really good. And if you really want to look at something, that is something that's reliable. And to Hawkeye's point, again, we just don't have any motivation to lie. We are not political folks. We are healthcare people.
All right. Are you prescribing exercise and better diet as a way to combat COVID, since obesity makes you more at risk? And it seems like some of the people with COVID may be overweight.
Yes, but that's no different than what I would say every single day, because obesity and being out of shape is a risk factor for almost everything you want to name. Diabetes, heart failure, cancer, name it. It's a risk factor. So it's not just a risk factor for COVID.
I've heard multiple sources say that kids 5 to 11 won't be eligible for the vaccine until December. I thought it was October. Can you help clear this up? Do we have any more information about that?
I don't think we do. I think we were all hoping it would be September, October as well. We knew that a big holdup is that the FDA wanted more information, so more patients to be in that trial, so they could attempt to find any of those rare side effects that may occur with that population. But again, I think this speaks to, number one, their transparency and their wanting to do their due diligence and looking for all those things. I suspect it's going to be safe. But
I do too. Let me pile on. I think it's about that myocarditis, pericarditis
Yeah.
as much as anything. And they've again, about 2 weeks ago, the CDC took this on and said, here's what we're seeing. We think that there's a whole lot more myocarditis and pericarditis with COVID-19, which is, by the way, that's inflammation of the heart muscle, tissue around the heart. There's a whole lot more of it in COVID-19, and it's much more severe, and it can really affect children. And if you remember the people from Children's Mercy talked to us about the makeup of the population in the ICU, they've seen a lot of that, and some of those kids are in the ICU and struggling. So, but what we're seeing with vaccination is very short-lived and doesn't relieve long-term damage. But I think that's what they're trying to do, to expand the number of patients in that pool to make sure that statement is true. What we know is as you get older, there tends to be less myocarditis and pericarditis, but as you're younger, there tends to be a little bit more of it. Again, that's not uncommon with a lot of viruses. It's just pretty severe with COVID-19. I don't think Hawkeye's right. What we're going to find is it's safe and that there is a risk of myocarditis, pericarditis in kids, but it's very unusual, far less risky than what's with COVID-19, and totally recoverable. I think that's where it's going to land, but we're just going to get more data.
Yeah, I mean, just to your point, there was a July 9th MMWR, that CDC publication that looked at myocarditis, and I think for males, their risk of myocarditis from infection itself was 6 times that of what it was from getting the vaccine. And for females of that age, it was actually 21 times higher if they got the actual infection compared to getting the vaccine. So,
Children's Mercy will be on Monday, so they may be able to add to that, and then maybe also add to this next question, which is, can you discuss the FDA Pfizer approval, and would the doctors prescribe off-label to kids?
But I won't, because I don't treat enough kids. I'm not a pediatrician, so I'm not comfortable with that one. But what I would say is, I want to pile on when a point Stan has made. The FDA reduced the time to get through the Pfizer data. But to be clear, they didn't reduce the work. They took more people and they worked 24/7 with extra shifts to get through the hundreds of thousands of pages of information. But they did not reduce the amount of information they had to review. I think that's a really important point. The FDA did and does do its job. And they asked Moderna for more information. Moderna finally has gotten everything submitted. Now, they had submitted beginning in June, but the FDA had come back to them and said, nope, we want more information. And remember, the FDA just doesn't look at the success of the drug. They visit all your production facilities. And they go and they see, how are you producing it, and does it look safe? And they make sure that all steps of the process. Then they look at your transportation, how your packaging is, what kind of, folks, the amount of detail that the FDA works at to make sure drugs are safe is what keeps you safe from drugs. And so I think that there's a lot of, you should have a lot of faith. The FDA is the milestone for the world around it. And we get frustrated, they're too slow, they're too bureaucratic. I'm sure there's probably truth to that. But at the end of the day, they inspect everything about drug production, distribution, outcomes, side effects, everything. And so I think they've not wavered around the Pfizer vaccine, and they're not going to waver around Moderna and J&J around that.
And I think, to clarify, when we say off-label, that's saying, we're using a drug that is approved for one thing, like if it's penicillin approved for a urinary tract infection, but it's approved for all these ages, whether adults or children. But even though it's not approved for a urinary tract infection, say we're using it for pneumonia. So that's kind of an off-label use. I think that there's no authorization or approval for those under 12. I don't think that meets the criteria of off-label, because you're just looking at a whole population that hasn't really even been studied. And so I think that's different than using the vaccine for that purpose. So I wouldn't necessarily say that's an off-label use. There's no authorization or approval for that age group. Really, it's only authorized for those people 12 and over. So I think using the word off-label or the term off-label is a little bit misleading there.
Dr. Comfort, your turn. You're up. Anil, good morning to you, by the way. He's
Hey,
a long hauler, a friend of our shows. He's been on. Hope you're doing well. He says, I saw studies coming out showing clotting markers increased in long haulers. Have you studied or seen any similar results to this?
Yeah, we have. So he's probably referring to the D-dimer. It's a specific test that we can check looking for evidence of blood clot. We know in the acute setting, in the ICU and the hospital patients, it's very high in that acute setting. But there are some patients where that D-dimer is remaining elevated long into the future. There are studies actively going on do we need to anticoagulate these patients, or do we need to put them on antiplatelets like an aspirin or something like that? Those are questions we don't know, but probably that's the utility of checking some of those clotting markers long into the future. So we do know that some kind of expert guidance is using it usually in that first 3-month period, but I've seen D-dimers elevated 6-9 months out. We just don't know what to do with that yet.
Hey, can I ask a question to Hawkeye? Because there was also to both of you, and I'm a little confused. I haven't gotten. There's an opinion piece. I haven't read it yet in the New England Journal. But this week, some conflicting data about the use of full dose anticoagulation versus preventive doses of Lovenox and heparin inside the hospital with ill and then critically ill patients, and whether or not you need full dose anticoagulation or just routine doses of anticoagulation, there are a big difference in the amount to help prevent serious effects of clotting. Do you have any thoughts, Hawk? I haven't looked at the articles closely enough yet.
Yeah, and I haven't. I had talked with Louis Satterwhite, who was actually on is an author on one of those studies as well, one of our ICU docs. I think it was just continuing to stay on the normal.
That's where they were landing. It was interesting, and not full dose anticoagulation, which is different than where we had been historically.
But I think he would be a better expert to kind of comment on those things, or any of our critical care docs.
And Dr. Comfort, Sandy wants to know about our long hauler clinic. Where can she find more information about it? Is there a brochure she can pick up? Is there a place on the website that she can find out more info?
Yeah, there is. So we have a web page that's kind of linked to the health system's web page. They can get information there. There's a phone number there. There's also a link there for referrals.
Great, thank you. Okay, so some claim that the vaccinated population is the primary source of spreading Delta. Any truth to that?
No. Oh my gosh. Please. Hawkeye, stop me from going on a rant.
Yeah, I mean, I think that's kind of backward thinking. I'm not sure where that came from. We do understand that probably if you're vaccinated, you can probably still spread the Delta variant, but early research showing that it is much less time that you have those higher viral loads. Your immune system quickly comes in to help reduce that compared to unvaccinated. So we would still say the unvaccinated population have more potential to spread it to others than does the vaccinated population.
Is it possible that people are thinking because people are vaccinated, now they're unmasking?
Yeah,
I'm just taking the layperson approach.
That may be, and I think that here's the key. First of all, that if you're vaccinated, your chance of spreading it is much reduced from the unvaccinated, but it's still present. And this is all about the Delta variant. You're not shedding virus for as long as you do with the Delta if you're unvaccinated, so that the real risk is with an unvaccinated population. I think if people are masked, they really reduce that risk, and that's why I keep pointing back to our data. We don't spread disease, whether it was the original strain, the alpha strain, or now the Delta variant. We don't spread it inside the hospital, and it's because good infection control works. So I think that's really the key to that.
And I think some of it was just maybe a misinterpretation of the CDC messaging or that morbidity and mortality weekly report that showed about the Provincetown, Massachusetts spreading events. So could be what it is.
What is the criteria to use ECMO, and are we in danger of not having enough equipment for patients that don't have COVID but that need ECMO?
Let me take on the equipment side of this first. And so ECMO is a strategy to try and help your lungs rest, or your heart rest, because your lungs and heart take a lot of damage from COVID-19. And so what we do is we take your blood out, we oxygenate it, and we give it back to you. And it's much more complicated than all that. But that's really at the heart of it, what we're trying to do. ECMO is something that has to be done in a critical care setting by people who are well trained in it. It is there's a lot of things that happen to your blood volume and other things during the time that we are using it, there's a lot of other things you have to do to help support somebody who's on it. It is hard work. It also doesn't have particularly good outcomes in COVID-19. Now, you're giving it to people who are heading towards death otherwise because they can't. They're having either too many compromise of their heart and lung, and again, you're just trying to give them time to heal. Our biggest dangers is we're typically out of ECMO beds in Kansas City, and the 3 hospitals that are doing ECMO are KU, Luke's, and Research. And there are a lot of times we're all turning down ECMO patients. There are 2 reasons you can be out of it. A, you can be out of equipment, which can happen because ECMO equipment that was in back order and you couldn't find it, and you can try and jury rig it, but that's hard to do. So you can run out of equipment. You can run out of staff, which is another big problem, or you may run out of the experts to help you manage it. So at the end of the day, the biggest threat to being on ECMO is we just don't have enough of it, and we have way too much need, and that's a problem. But again, the people who are on it are so darn sick they don't have a great outcome. There are a few that survive, and that's why we try and do it. But as far as the ECMO criteria, it's kind of what I just hit, right? That is really the ECMO criteria. It's more sophisticated than that. But we review every case as to the folks over at Luke's and HCA to try and figure out who can be on it. But we're really trying to get to people we think we can help salvage, we can help survive. And you don't want them to have a ton of other comorbid illnesses. You know, a great example is we had a 25-year-old postpartum patient who just had a baby that had COVID-19, and that is a bad combination. COVID-19, pregnancy, unvaccinated. That's a really dangerous combination. And so they crashed, and they needed life support like ECMO. And those are the kind of people we try and put on. We've all had a struggle getting people on it, though, and we're having to deny some of those patients.
Okay, do I have time for one last question from today, and then I have a comment also? Is that good for you? Are you guys good? Okay. Heather and Jill have a similar question. Where do you go to get monoclonal antibodies therapy in Kansas, and do you have to be high risk to get the antibodies?
Yeah, certainly there are criteria. There has been an uptick in the requests for the monoclonal antibodies, so you would meet criteria. The basic criteria under the emergency use authorization, which is again is the base that we start from, because we can only offer it to some people. So that's 12 and above, weighing more than I think it's 40 kilograms. So that's the base, and then from there are criteria for age, other comorbidities. Really, we are focusing this toward those patients that are the highest risk to go to the hospital and have those severe outcomes. There is outside referral for here at the health system for our monoclonal antibody infusion as well. And so that referral can be made. But I think around the city they are looking to have some other access areas as well.
Okay, so Jacqueline, I promised I would ask your question today, but I'm actually going to save it for Children's Mercy.
And I would say, sorry to interrupt,
Sure.
I would say also that we are waiting for some emergency use authorization to be able to use those monoclonal antibodies for hospitalized patients. The data has been submitted, the application has been submitted. We are ready to go with that when that authorization does come through, and that will be a specific population as well.
So Jacqueline, I'll ask your question, but she had a really nice comment. I just do want to read it to you. She said, I want to thank you for your continued education of COVID-19. You are my go-to source of information as a Kansas City resident. I do appreciate your science-based perspective and your human touch.
Well, we try.
You try, I know.
Sometimes I'm touching the microphone, apparently.
Yeah,
That's
that-
what Logan and Anthony keep trying to tell me.
Yeah,
Long and prosper, brothers.
Human touch, not microphone touch.
That's a
Okay.
good Bruce Springsteen song.
And then Jennifer just said, she said, a future program, I would be very interested in a day in the life of Dr. Hawkinson and Dr. Stites. All the things they do. They read so much. How do they keep up? Do they have time for themselves? She thinks that would be a fascinating show. Can we follow
Okay.
you around?
That's up to y'all.
What would we find out?
Yeah.
Is it really interesting?
I don't know if it's interesting. It's
Lots
a
of
little.
meetings?
It's a lot of meeting, a lot of helter skelter, a lot of running.
All right. Well, people find you fascinating.
Well,
Just deal with it.
man.
You have to deal with
Oh
it.
my
Sorry,
God.
I don't know.
I don't know
Okay,
about
okay, we want to get to our final thoughts. Dr. Comfort, thanks so much for being with us today. Final thoughts as we head out to the weekend?
Thanks for having me. One thing I'll just say on the misinformation stuff, I've found that people really listen to their friends and family members. So if you've got your vaccine, please go out, tell your friends, tell your family that you had a good experience, because we really need to get everybody vaccinated. That's our ticket out of this pandemic. So that's my final thought.
Great message. Thanks so much for being here. And I will never turn my back on you again. Dr. Hawkinson, your final thoughts. Sorry about
Sometimes
that.
I have things to say.
You do. Just jump right in.
I would like to
Wow.
say thank you to Dr. Comfort and his multidisciplinary colleagues looking to help make everybody's life who has long-haul COVID, their quality of life improved, because we know the impact that long COVID has. So thank you to you and your colleagues. Again, multiple different clinics, pulmonary, ENT, rehab medicine, all of that. So it is very important, because we know that healthier people have better quality of life. The economy's better, so it is difficult, and we will just probably see more and more long-haul people. So again, also just to echo, really continue to talk with those people that have concerns or have thoughts. I think it's really getting them into where are these sources of truth. We've tried to provide some of those. We will continue to try to provide that as well. And our lives aren't very exciting. There is a lot of reading. Missing reading or articles or anything like that for more than a day, you really feel left behind on these. So otherwise, it's just regular stuff.
You've got them all full.
We're
They
just
think
like
you guys
regular
are-
people too.
Yeah, and I got a stat call from my nurse, so I'm going to be brief because I got to go answer her.
All right,
here
your
it
final
is.
word then.
Here it is. Today is not forever, and tomorrow is not yesterday. Only one person can make that true. It's you.
That's it. I like it. Okay. Thank you so much, everyone, for being with us today. We are back on Monday with Dr. Angela Myers. She is the Infectious Disease Division Director at Children's Mercy. She'll answer all those questions that you sent in today about your kiddos. She's going to answer questions about COVID, the kids, vaccine, and what the patient load is like since the last time we had her on our program last week. We'll get all updated on that Monday morning starting at 8. Enjoy your weekend. Stay safe. Get vaccinated.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.